Welcome back to the Deep Dive. Today, we're embarking on a journey that, well, it truly touches everyone. We're exploring the profound and often miraculous process of human reproduction.
Yeah, it's fascinating stuff.
We'll be moving from the microscopic, that dance of cells at conception, all the way to the complexities, the breathtaking complexities of new life arriving.
And it's a field that's constantly evolving, isn't it? It demands both incredible precision and real compassion from everyone involved.
Absolutely.
Yeah.
So let's begin this deep dive into obstetric foundations. Now, for those of you tuning in who are BSN nursing students, this is really designed as a crucial pre-class module.
It's your jumpstart.
Exactly, your jumpstart into understanding the fundamental concepts that are going to underpin your entire semester. We're going to cover, well, basically everything from the intricate dance of reproductive anatomy and physiology
To the miracle of conception and prenatal development.
and then shift into the really practical stuff like family planning, infertility, and essential women's health. Our mission here really is to distill these often complex topics into clear, actionable knowledge. It's vital background for providing care before, during, and after pregnancy.
We're aiming to pull out the most important insights, those sort of surprising facts you'll need to feel genuinely well-informed and, confident in your practice.
Right.
And this isn't just about memorizing facts for an exam. It's profoundly about real-world application. Grasping these foundational elements is absolutely essential for delivering safe, equitable, and evidence-based care.
In all kinds of settings too, right?
Exactly, across every setting you might encounter, whether you're in a community clinic, assisting in labor and delivery, providing that crucial postpartum support, or offering ongoing women's health services.
Okay.
The ultimate goal, really, as we see it in practice, is to make sure care is culturally responsive, trauma-informed, and empowers you, the future nurse, to apply dynamic clinical judgment even in the most critical scenarios.
Okay, so to really get a handle on modern maternal and newborn health, we kind of have to appreciate the dramatic shifts that have happened.
Oh, absolutely. Over the last century, it's been transformative.
We're talking about incredible advancements in scientific knowledge, technology, things that have fundamentally reshaped what's even possible.
Yeah, think about diagnostics, life-saving interventions. It's night and day compared to before.
But it wasn't just science, right? There was expanded government funding, more regulation.
Right, creating frameworks for care. But at the same time, you had these intense cost containment pressures pushing systems to be more efficient.
And patients started demanding more say, too.
Exactly. That rise in consumer demand for shared decision-making was huge, empowering patients to be active participants.
So all these forces, they combine to create this incredibly complex, dynamic environment for healthcare providers today.
And when we step back and look specifically at the U.S. context, this complexity presents a pretty stark reality, doesn't it?
Yeah, what do you mean?
Well, despite all these advances, it's a sobering fact that our maternal and neonatal outcomes, they continue to lag behind many other developed nations.
That's concerning.
It is. And it's not just a statistic. It underscores an urgent, ongoing need for continuous improvement in our healthcare systems and practices. It demands, critical self-reflection and proactive change.
That's a powerful challenge. So how do professional nurses step up to meet that?
Well, this is precisely where professional nurses become absolutely indispensable. In this rapidly evolving landscape, patient safety and quality are just paramount.
Right.
Nurses are the frontline experts. They're consistently leveraging critical thinking, sound clinical judgment, and that structured nursing process.
And they're guided by standards, evidence.
Constantly. Their practice is guided by national standards and the latest evidence-based guidelines, making sure every decision is informed and optimized for the best possible outcome.
Okay, but when we talk about outcomes, we have to confront the really troubling disparities that exist, don't we?
Indeed. We absolutely do. High maternal and infant mortality rates are a major global and national concern, yes. But critically, outcomes vary widely across different populations. It reveals profound inequities.
Like,
Well, for instance, geographic disparities are stark. Rural areas, often lacking specialized facilities or maybe just easy access to care, they experience proportionally more adverse maternal and neonatal outcomes compared to urban areas.
okay.
But perhaps even more alarming are the racial and ethnic disparities. It's just undeniable that social determinants of health,
Things like income, education, where you live.
exactly, economic stability, education, neighborhood environment, healthcare access, social context, all those things, combined with implicit bias, systemic racism, and other pervasive inequities. They contribute significantly to higher rates of illness and death among many racial and ethnic groups.
Wow.
To give you a concrete example,
Yeah.
the CDC reported an increase in U.S. maternal mortality from 17.4 deaths per 100,000 births in 2018 to 20.1 deaths per 100,000 births just a year later in 2019.
That's a significant jump.
It is. And it isn't just a number. It's a clear signal of these deep-seated systemic issues that demand our immediate and sustained attention. It's a real call to action.
It definitely sounds like it. So who are the key organizations pushing for change in this space, trying to address this?
Well, two crucial players come to mind immediately. First, there's the Joint Commission, or TJC. They're an independent accrediting body, and they vigorously promote continuous quality improvement and safe, effective care through standardized practices.
So they're kind of like the quality control?
You could say that, yeah.
Yes.
The quality assurance arm for healthcare facilities.
Yeah.
And then there's Healthy People 2030. This is a national framework. It sets ambitious, evidence-based 10-year objectives to improve the overall health and well-being of the entire U.S. population. Think of it as a national roadmap for public health efforts.
Okay, now here's where it gets really interesting, especially for those of you stepping into a nursing role soon. Cost containment. We mentioned it, but it has dramatically shortened hospital stays.
Oh, drastically.
We're talking typically just 24 to 48 hours for a vaginal birth, maybe 72 to 96 hours for a C-section.
It's incredibly brief.
So imagine being a new parent, you're exhausted, recovering, and you have this tiny window to absorb all that crucial discharge teaching.
Yeah, it compresses essential education into a very brief period, often when clients are, frankly, least able to take it all in. They're fatigued, uncomfortable.
It's a massive challenge. It forces nurses to be incredibly efficient and maybe even creative in how they teach.
This raises an important question then. How do nurses maintain quality amidst these relentless pressures?
Yeah.
They rely heavily on national professional standards. These come from organizations like AHON, that's the Association of Women's Health, Obstetric, and Neonatal Nurses,
Okay.
ACOG, the American College of Obstetricians and Gynecologists, and the AMIS, the American Academy of Pediatrics.
So these are the big names.
They're the backbone of clinical excellence, really. They publish vital standards, education guides, practice guidelines. It's the blueprint for safe and effective nursing care.
And underpinning all of that is something called evidence-based practice, or EBP. What exactly is that?
Right. EBP is basically the integration of the most current, rigorous scientific evidence with a nurse's own seasoned clinical expertise, and crucially, the individual patient's values and preferences.
So it's bringing it all together.
Exactly. All aimed at improving outcomes. AHON, for instance, plays a pivotal role here. They actively develop and disseminate EBP guidelines, making sure nurses have access to the most up-to-date best practices.
And there are others involved, too.
Oh, yes. The Agency for Healthcare Research and Quality, or AHRQ, sponsors critical maternal-child health research and provides clinical practice guidelines that directly inform how care is delivered. It's this constant collaborative effort to refine and enhance patient care.
Now let's talk about the essential toolkit for every professional nurse. Critical thinking, clinical judgment, and the nursing process. These aren't just buzzwords, are they?
Not at all. They're deeply interrelated and absolutely foundational to daily practice.
Okay, break them down for us. Critical thinking.
That's that disciplined, systematic approach you take to forming judgments and making decisions. It involves both the skills you cultivate over time and your overall mindset, how you approach problems.
Got it. And clinical judgment.
That's the dynamic application of that critical thinking and knowledge to specific clinical situations. It's how you quickly prioritize concerns and select the most effective actions right there in the moment.
Okay. And for you nursing students listening, it's worth noting that the NCSBN Clinical Judgment Measurement Model, the CJMM, it's so central, it actually underpins the next generation NCLEX exam questions.
Right. It's the framework for testing how new nurses make decisions.
And finally, the nursing process.
That's the core of registered nurse practice. It's a systematic, scientific reasoning approach. It includes 5 key steps: assessment, analysis, planning, implementation, and evaluation.
Sounds very step-by-step.
Well, it's taught that way, as a linear framework. But experienced nurses apply it much more dynamically, in real time. Imagine you're doing an early postpartum assessment, and you quickly note the client has a distended bladder.
Okay.
An experienced nurse doesn't just rigidly stick to the checklist. Instead, they prioritize assisting that client to void immediately. Why? To prevent discomfort and potential excessive bleeding from the uterus being displaced.
Right. Makes sense.
Then they return to complete the full assessment. That, right there, That's dynamic nursing in action, using critical thinking and clinical judgment to provide immediate, impactful care.
Okay, so what does this all mean for providing truly holistic care? Beyond the biological facts, we absolutely have to consider the profound impact of social, cultural, and ethical imperatives in healthcare.
Absolutely fundamental.
The family, it's the basic unit of society. It's where people learn values, norms, expected behaviors. So every family exists within a unique cultural context.
And that context profoundly shapes their beliefs, their traditions, their decision-making, especially during huge life events like childbirth and parenting.
Right. And maybe we should quickly distinguish. Culture refers to that collection of learned and shared beliefs, values, practices passed down.
While ethnicity is more about group identity based on common race, language, traditions, symbols.
Got it. And this understanding is exactly why transcultural nursing, which focuses on providing care with sensitivity and respect for diverse backgrounds, is so incredibly vital. It's about truly meeting people where they are.
What's fascinating here is how deeply cultural values, which often differ significantly from, say, dominant Western norms, impact nearly every single facet of care.
Like what?
Well, from fundamental communication styles to crucial decision-making processes. Take communication. For example, some Asian clients might nod or smile politely.
Indicating they're listening.
Exactly, I hear you. But that doesn't always mean agreement or full understanding. So the critical takeaway for healthcare professionals is to verify comprehension. Ask clients to teach back or show back.
Like, tell me in your own words, or show me how you do this.
Precisely. Or, for Hispanic Latino clients, spending a few moments on small talk to build confianza or trust isn't wasting time. It's actually a productive use of time that lays the groundwork for achieving care goals.
Interesting.
And with some American Indian Alaska Native clients, speaking softly and trying to remember details rather than taking copious notes can be perceived as more respectful.
Yeah.
Excessive note-taking can sometimes be viewed as taboo.
That's a powerful insight. It's not just what we say, but how we engage, how we show respect.
Exactly. Then understanding who holds decision-making authority is absolutely key. Is it the individual, the partner, maybe the extended family, or even traditional leaders?
Right.
When decisions are collective, you simply must include those key decision makers in your education and planning. Otherwise, it won't stick.
And even something like eye contact.
Even something as seemingly universal as eye contact carries different meanings globally. While many white and African American clients might see direct eye contact as a sign of honesty.
In some cultures, it's different.
Right. In certain American Indian Alaska Native communities, avoiding eye contact actually signals respect. Among some Middle Eastern cultures, eye contact between unrelated men and women might be considered inappropriate. And for some Latino families, there's the belief in mal ojo, or the evil eye, where too much overt admiration could potentially cause harm to a child. So caregivers need to be mindful of intense eye contact, or maybe overly enthusiastic comments with infants.
And touch, which seems so natural in care settings, that probably has cultural nuances too.
It absolutely does. Touch can carry vastly different meanings. In some cultures influenced by Hinduism or Islam, touch by a woman who isn't the wife might be offensive to men.
Oh.
Conversely, many Hispanic clients might appreciate touch as a sign of sincerity or warmth. The guiding principle here is always to assess the client's comfort level and immediately stop if touch feels unwelcome.
Makes sense.
Spirituality and religiosity are also deeply personal. Clients may hold profound beliefs and practices, but they might feel reluctant to share them. For instance, Kai clients might reference 3 essences: body, mind, heart, and energy in their health practices.
So what should nurses do?
Respectfully invite discussion, listen actively, and incorporate practices when it's safe and feasible to do so. And finally, time orientation. Differences in views of time can create significant friction in healthcare.
How so?
Some American Indian Alaska Native, Middle Eastern, and Hispanic Latino clients may emphasize the present much more than the future. So if punctual appointments aren't seen as a high priority, clients might encounter frustration in clinical settings.
And then maybe avoid care altogether.
Exactly, which can profoundly impact their health outcomes.
That really broadens the concept of culture, doesn't it? It goes way beyond just ethnic identity.
It does, profoundly. Culture extends to encompass survivors of abuse, clients who prefer traditional birth settings like home birth, individuals living with poverty or low health literacy, clients who have experienced female genital cutting.
People with disabilities, mental health challenges.
Precisely. These are all critical cultural contexts that shape a person's experience of care and demand our sensitivity. And they're also culturally grounded health concepts, too, like some Asian traditions emphasizing that balance between yin and yang, or some Hispanic traditions balancing hot and cold in health and diet.
So the nugget here for future nurses is,
It requires immense creativity, flexibility, and resilience to meet these incredibly unique needs in any clinical setting.
so what does this culturally competent care actually achieve? What are the benefits for patients?
The outcomes are really significant. You see stronger therapeutic relationships, fewer complications, better adherence to treatment plans, and crucially, increased trust between clients and providers.
And trust is everything.
It's the bedrock of effective care. Culturally competent nurses proactively assess needs and use culturally appropriate health education materials. But we also have to acknowledge common barriers.
Like language.
Language, yes. Also sociocultural differences, lack of insurance or financial resources, maybe limited health knowledge, sometimes a reluctance to question providers, or just unfamiliarity with the whole biomedical environment.
Can you give an example?
Sure. Higher levels of modesty and religiosity among some Muslim clients, for example, may contribute to them delaying prenatal care. This underscores why care absolutely must be built on awareness, sensitivity, respect, and sometimes cultural negotiation.
And building on that, perinatal nurses must proactively assess social determinants of health, or SDOH.
Yes, absolutely critical.
This means really understanding a client's socioeconomic status, their poverty levels, whether they're experiencing homelessness, because these factors profoundly influence childbearing practices and their access to vital services.
We see this play out frequently when clients delay seeking care, don't we?
Yeah, sometimes they don't even realize they're pregnant, or maybe they fear confirmation or having to disclose the pregnancy.
Or they might be considering abortion or feel depressed about an unintended pregnancy.
Right. Still others might just rely solely on family advice or simply believe that prenatal care isn't necessary if they're feeling okay.
So the core takeaway for nursing students here is this imperative. Treat every single family with profound respect and actively work to eliminate racism and inequities in all their forms. Your actions truly matter.
Absolutely.
This raises another important question about inclusivity, especially concerning LGBTQ+ families.
Right, because the landscape is changing.
It really is. With a rising proportion of U.S. adults identifying as LGBTQ+ heir, particularly among younger generations like Gen Z and millennials, nurses absolutely must use inclusive language and practices.
So traditional terms like mother and father.
They're inherently gendered, aren't they? And they can inadvertently alienate or misgendered individuals. It is absolutely crucial to always ask clients about their preferred names and pronouns.
And document them clearly.
Yes, so the entire care team uses them consistently. Until you know their preferences, it's best to avoid gendered terms like mama or dad. Use the client's name or neutral terms like partner or support person.
And this inclusivity is particularly vital for transgender men who become pregnant.
Yes, they can face substantial barriers to prenatal care. So having inclusive policies, welcoming environments, and staff who are informed and sensitive is essential to ensuring they receive the care they need without discrimination.
The key insight here seems to be that sensitive care isn't just respectful, it's actually a critical component of positive health outcomes for all people.
Couldn't agree more.
And unfortunately, we also need to address the very real, often hidden issue of intimate partner violence, or IPV.
A difficult but necessary topic.
ITV is defined as abuse, physical, sexual, or emotional, by a current or former partner or spouse. The statistics are startling. Approximately 1/3 of adolescent and adult women have experienced IPV.
And shockingly, abuse can actually begin or intensify during pregnancy. Up to 20% of pregnant clients might experience physical abuse.
Wow. It's so common. It's one of the most frequently screened for complications during pregnancy.
It has to be, because the associated risks are severe. Delayed prenatal care, uterine rupture, placental abruption, preterm birth, low birth weight infants, even maternal and fetal death.
And beyond the physical.
It also increases the risk of STIs and perinatal depression. Plus, IPV can foreshadow child abuse, and just witnessing violence is directly linked to significant psychological, social, emotional, and behavioral harms in children.
So for nurses, knowing these red flags and providing a safe space for disclosure is just paramount.
Absolutely. And what's truly critical here is how human trafficking intersects with healthcare and how vital the nurse's role is in its identification.
Define human trafficking for us again.
It's the recruitment, harboring, transport, provision, or obtaining of a person for labor, commercial sex, or domestic servitude through force, fraud, or coercion.
And it's widespread.
Global estimates suggest around 24.9 million people are trafficked annually, yet perhaps only 1 in 100 victims are ever identified. It's largely hidden.
And it affects women and children disproportionately.
Yes, women and children of childbearing age constitute the majority of reported cases, with the average entry into trafficking often occurring during their reproductive years.
Mm-hmm.
The health outcomes are horrific.
Like what?
Increased rates of HIV and other STIs, pelvic inflammatory disease, unsafe abortions, significant reproductive trauma, plus severe mental health issues, anxiety, depression, suicidal ideation, self-harm.
So the clinical imperative here is...
It's profound. Victims rarely self-identify, often because they're controlled and isolated. Nurses are uniquely positioned to recognize red flags and patterns.
Give us an example.
Think of a non-English speaking minor who doesn't know their own address, presents with multiple prior abortions, and is accompanied by a controlling older person who prevents them from speaking freely.
That's a major red flag.
It is. This is where your critical judgment literally saves lives. As perinatal nurses, you are on the front lines, uniquely positioned to begin that vital chain of recognition, analysis, and intervention. You're an unexpected but crucial first responder.
This brings us to another critical area, ethics in reproductive health care and how cost control plays into it.
Right, bioethics.
Bioethics is about applying ethical principles to healthcare, ensuring respectful, dignified care as a fundamental human right. But conflicts can arise, can't they?
They can, especially when client behaviors, like substance use or refusal of recommended care, could potentially harm a fetus or are, socially disapproved.
So you have maternal rights and fetal rights to consider.
Exactly. And it requires a nuanced, unbiased approach from healthcare providers. It's complex territory.
Indeed. And elective pregnancy termination or abortion has long been a profoundly contentious legal and ethical issue.
Hugely contentious. Historically, Roe v. Wade in 1973 established a constitutional protection for abortion based on a right to privacy.
But that changed recently.
Yes. Domsey-Jackson Women's Health Organization in 2022 overturned Roe. This fundamentally shifted the regulation of abortion back to individual states.
So the legal landscape is very fragmented now.
Very much so. And the ongoing debates persist, particularly around the complex question of when life actually begins. Is it at conception or at fetal viability, which is roughly 22 to 24 weeks?
So what's the role of healthcare providers in this?
Our role is really to impartially convey the facts and the current legal landscape, while always providing compassionate, non-judgmental care within the bounds of the law, regardless of our own personal viewpoints.
Okay. And then we have the pervasive impact of cost containment, which continues to shape perinatal care.
We keep coming back to it because it's so influential.
It includes the increased use of unlicensed assistive personnel, or UAPs, and as we discussed, those significantly shorter hospital stays.
Yeah.
So for future nurses, it's crucial to remember that while UAPs can perform certain tasks, taking vital signs, assisting with bathing, feeding, ambulating,
The registered nurse remains legally responsible for the assessment and the critical judgments.
right. UAPs cannot interpret measurements or make clinical judgments based on them. That's strictly the RN's domain.
And to address the challenges of early discharge, nurses have had to adapt creatively, haven't they?
They really have. The key strategy seems to be beginning essential teaching right at admission.
Or even better, starting self-care education during pregnancy itself, when clients are generally less fatigued and maybe more receptive to learning than they might be immediately postpartum.
That makes sense. It's a proactive approach to help ensure clients are as prepared as possible when they go home, even with those shorter stays. Okay. To truly appreciate the miracle of new life and to provide effective care, a solid understanding of reproductive anatomy and physiology is absolutely essential.
It's the foundation for everything else.
Whether you're providing routine care, counseling on family planning, or supporting a couple through the often difficult journey of infertility, this knowledge is your bedrock. It all starts, really, with sexual development, which has fascinating origins long before birth. Genetic sex, XX or XY, that's actually fixed right at conception, depending on the sperm.
Right. But for the first 6 weeks or so, the internal and external genital structures are undifferentiated. They haven't declared male or female yet.
So when do the differences appear?
Around week 7, internal differences start. Then external differences around week 9, usually complete by about 12 weeks.
And what drives that differentiation?
The key driver is testosterone. Its presence triggers the development of male structures. In its absence, female structures develop by default, essentially.
Fascinating. Then after a period of relative quiet during childhood, we hit puberty or sexual maturity.
Right. At puberty, the hypothalamus gradually ramps up its production of gonadotropin-releasing hormone, GnRH, usually starting around ages 9 to 12.
And GnRH acts like a...
Like a conductor. It signals the anterior pituitary gland to release follicle-stimulating hormone, FSH, and luteinizing hormone, LH.
Okay.
These, in turn, tell the ovaries to increase sex hormone production and begin that incredible maturation of gametes, the eggs.
And puberty itself isn't instant, is it?
No, not at all. It's a years-long sequence of changes during late childhood and early adolescence when the reproductive organs become fully functional.
For nurses, it's important to distinguish between primary sex characteristics
Which are the direct maturation of ova in the ovaries and sperm in the testes.
and secondary sex characteristics. Those are the visible changes, right?
Exactly. Things like breast development, the characteristic fat distribution more around the breasts, buttocks, thighs, and the growth of pubic and axillary hair, plus voice changes.
And for females, what's usually the first sign?
The first visible sign of puberty in females is usually breast development, called the larche, typically occurring between ages 8 and 13.
And then menarche, the first period.
That generally falls about 2 to 2.5 years after the wash, usually somewhere between ages 9 and 16.
Okay.
What's truly fascinating here is the intricate symphony of hormones that orchestrates this entire female reproductive system. It's a remarkable cascade where each hormone plays a very precise role.
Let's walk through them. Start with GnRH.
Okay. GnRH, gonadotropin-releasing hormone, really kicks off the whole process. It stimulates that pulsatile release of FSH and LH from the pituitary. That initiates puberty and then sustains the cyclical function throughout a woman's reproductive life.
Then FSH.
FSH, follicle-stimulating hormone, lives up to its name. It stimulates the growth and maturation of ovarian follicles, basically preparing those potential eggs.
And LH.
LH, luteinizing hormone, is the crucial trigger. Its mid-cycle surge is what actually causes ovulation, the release of the egg. It also promotes the formation and function of the corpus luteum.
Which is what's left after the egg is released.
Exactly. And the corpus luteum continues to secrete estrogen and progesterone for about 12 days if fertilization doesn't occur. If pregnancy does happen, the placenta then gradually takes over this vital hormone-producing role.
Okay, and what about the main sex hormones themselves? Estrogen and progesterone.
All right. Estrogen, during pregnancy specifically, is responsible for enlarging the uterus and breast tissue, preparing the body for the growing fetus. It also temporarily inhibits active milk production and helps relax pelvic ligaments, which is crucial for childbirth.
And progesterone.
Progesterone is absolutely essential for maintaining pregnancy. Think of it like a nourishing blanket for the embryo. It prepares and sustains the uterine lining and the fallopian tube cells.
And it stops contractions?
It reduces uterine contractility to help prevent premature labor, yes. And it also prepares the breasts for lactation while inhibiting active milk secretion until after birth. Beyond pregnancy, of course, both estrogen and progesterone are key players in the regular menstrual cycle.
Are there other key hormones involved?
Yes, definitely. Prolactin initiates and maintains milk synthesis. During pregnancy, those high estrogen and progesterone levels actually suppress full milk production. But once the placenta is delivered, the infant suckling rapidly increases prolactin levels, sustaining milk production.
And the famous love hormone.
Oxytocin. It has two critical roles in this context. It stimulates uterine contractions during labor and postpartum that helps compress uterine blood vessels and limit bleeding. And it's also the key hormone that triggers the milk ejection reflex, or letdown, during breastfeeding. It's truly a perfectly orchestrated biological dance.
Incredible. Now, let's zoom in on the female reproductive anatomy, detailing the structures and their remarkable functions. Give us the overview.
Okay. The vagina serves as the passageway for menstrual flow and is the birth canal. The uterus is that hollow, muscular organ that expertly houses and nourishes the fetus and then contracts powerfully to propel the fetus out at birth.
The fallopian tubes.
Narrow passageways for the ovum as it travels from the ovary to the uterus. Crucially, they are the typical site of fertilization.
And the ovaries.
The powerhouses that secrete estrogen and progesterone and release the eggs. And the breasts, while not directly reproductive organs, are the mammary glands that support lactation.
All right, let's look at the external organs, often collectively called the vulva.
Right. You have the mons pubis, that rounded fatty area over the pubic bone. The labia majora, or the two outer Hair-bearing folds that protect the more delicate inner tissues
Inside those.
are the labia minora. These are hairless, highly vascular folds that engorge with blood when stimulated. The clitoris is a small, highly sensitive erectile structure, covered by a hood-like prepuce formed by the labia majora.
And the vestibule.
That's the space enclosed by the labia minora. It contains the urinary meatus, where urine exits, the vaginal introitus, which is the opening of the vagina, and the ducts of the Skene and Bartholin glands, both of which provide essential lubrication.
What about the hymen?
The hymen is a thin mucosal fold that partially separates the vagina and vestibule, but it's really important for nurses to note its integrity is not a reliable marker of virginity. That's a common misconception.
Good point. And the perineum.
That's the posterior portion of the external organs, extending from the fourchette, just below the vaginal opening, to the anus. It provides crucial fibromuscular support for all the pelvic structures.
Okay, moving internally. Tell us about the vagina.
It's a muscular tube, about 8 to 10 centimeters long, located between the bladder and the rectum. Its mucosa has folds called rugae.
Like stretchy pleats.
Exactly. Allowing for significant expansion during childbirth. It functions as the passage for menstrual flow, is the organ of sexual intercourse, and serves as the birth canal.
And the uterus.
A hollow, thick-walled muscular organ shaped like an inverted pear. It cyclically prepares for possible implantation each month. The cervix is the tubular lower neck of the uterus, about 2 to 3 centimeters long.
And this is what changes dramatically in labor.
Incredibly so. It thins out, which we call effacement, and opens up, which is dilation. It has an internal os separating it from the main part of the uterus, and an external os opening into the vagina.
Then the fallopian tubes.
These are narrow, delicate tubes that transport the ovum from the ovary towards the uterus. Their inner lining has ciliated epithelium, tiny hair-like structures that help propel the ovum along.
And fertilization happens here.
Typically, yes. But crucially, these tubes are susceptible to scarring or blockage from infections, like STIs. This can unfortunately lead to infertility or even life-threatening ectopic pregnancies where the pregnancy implants in the tube itself. So they're quite delicate. Very. The fimbriae at the end of the tubes are like little waving fingers that help draw the ovum into the tube during ovulation.
And what holds all these organs in place?
Several things. The pelvis, that basin-shaped bony ring forming the true pelvis, is critically important in childbirth. It determines the pathway for the baby. Then you have pelvic muscles and fascia, particularly the levator ani group, which resist increases in intra-abdominal pressure, like when you cough or lift.
Right.
And finally, a network of ligaments maintains organ position and protects the neurovascular supply.
Okay, so the female reproductive cycle then is this regular, exquisitely synchronized series of changes.
In anterior pituitary secretions, FSH and LH, ovarian function, estrogen and progesterone, and the uterine endometrium, or lining.
And even cervical mucus changes.
Yes, concurrent changes in cervical mucus specifically favor fertilization right around mid-cycle. A typical cycle length is about 28 days, though the normal range is quite wide, maybe 20 to 45 days.
But significant deviations might mean reduced fertility.
Often, yes. And a key point to remember for dating cycles is that day 1 is always considered the first day of menstrual bleeding.
Got it. Finally, let's consider the female breast. Not directly reproductive, but vital for the newborn.
Right. Mammary glands that uniquely produce milk after childbirth. Each breast has a central nipple of erectile tissue and a pigmented areola.
And those little bumps on the areola?
Those are Montgomery tubercles, small sebaceous glands that enlarge during pregnancy and lactation to keep the nipple supple and lubricated. Inside, there are 15 to 20 lobes of glandular tissue, arranged like spokes around the nipple.
And within the lobes.
Tiny structures called alveoli synthesize milk from components brought by the blood. Surrounding these alveoli are myoepithelial cells. When oxytocin hits them, they contract.
And eject the milk.
Exactly, into the lactiferous ducts, which then converge at the nipple. And it's important to reassure new parents that breast size primarily reflects fat content and does not predict milk-producing capacity.
Good point. And how does function change over time?
At puberty, rising estrogen promotes glandular growth and fat deposition. During pregnancy, placental estrogen and progesterone stimulate the growth of more alveoli and ducts. Prolactin actually initiates milk synthesis during pregnancy.
But doesn't flow freely then?
Right, because those high levels of estrogen and progesterone suppress full milk production until the placenta is delivered. After birth, infant suckling then maintains prolactin levels, sustaining milk production, and oxytocin mediates that crucial milk ejection or letdown reflex, making milk available to the baby.
Okay, let's embark on that incredible journey of life. Conception and prenatal development. It all begins with conception.
which occurs when a healthy, motile sperm meets and penetrates a mature ovum released at ovulation, and the timing is tight.
Right. The ovum is viable for only about 24 hours.
No more than that, typically. And while most sperm survive up to 24 hours in the female tract, a small fraction might remain fertile for up to maybe 80 hours.
So there's a fertile window.
Definitely.
Mm-hmm.
After fertilization, the journey continues through distinct stages. The preembryonic period spans the first 2 weeks. This is marked by rapid cell divisions from zygote to morula, then blastocyst.
And implantation.
By about day 4, the zygote reaches the uterus, and implantation into the receptive endometrium progresses, usually completing by the end of week 2.
This is where it gets really intricate, doesn't it? The embryonic period.
Absolutely. This extends from week 3 through week 8. And this is the absolutely critical phase of organogenesis. Meaning the basic structures of all major organs are laid down during this short, intense burst of development.
Which makes the embryo very vulnerable.
Highly susceptible to teratogenic injury during this time. Think about it. Exposure to harmful substances, certain medications, infections, alcohol, even significant nutritional deficiencies during this small window can have profound and lasting impacts on development.
Okay. And after week 8?
From week 9 until birth, the fetal period begins. By this point, all major systems are present, at least in a primitive form. The focus shifts dramatically to rapid growth and functional refinement, getting everything ready for life outside the womb.
It's truly incredible how much development happens in such a short time.
It is, and this raises an important question. How does this complex development occur and sustain itself? How does it get nutrients and oxygen?
Right.
It's supported by 3 crucial auxiliary structures that develop right alongside the embryo and fetus: the placenta, the umbilical cord, and the fetal membranes.
Let's start with the placenta.
It's a thick, disc-shaped organ with distinct maternal and fetal components. The fetal side is smooth, covered by membranes with branching blood vessels. The maternal side is rough where it attaches to the uterine wall.
And the blood mixes.
Correctly? No. Maternal and fetal blood do not mix. Instead, they flow in very close proximity within intervillous spaces, separated only by thin villous membranes.
Why is that separation so important?
It allows for essential exchange of gases, nutrients, and waste without mixing. This is vital, especially if the maternal and fetal blood types are incompatible. The fetal heart drives the circulation of blood between the fetus and the placenta via the umbilical cord vessels.
Which brings us to the umbilical cord, so it's literally the lifeline.
Exactly. It's the physical lifeline between the fetus and the placenta. Normally, it contains 2 umbilical arteries,
Which carry?
deoxygenated blood and waste products away from the fetus to the placenta, and 1 umbilical vein,
Carrying.
oxygenated nutrient-rich blood from the placenta back to the fetus.
And it's coiled.
Yes, the vessels coil within the cord, which allows for flexibility without them getting easily occluded or kinked. And they're embedded in Wharton's jelly.
What's that?
It's a special gelatinous substance that cushions the vessels against compression. It's like protective padding.
Okay. So the placenta itself, what are its main jobs?
It performs several vital functions. Metabolically, it actually synthesizes nutrients like glycogen, cholesterol, and fatty acids for both embryonic and its own needs.
Wow, it makes its own stuff.
It does. Then for transfer, it expertly exchanges oxygen, nutrients, and wastes across those chorionic lines, using various mechanisms like diffusion and active transport. But here's the critical takeaway for anyone involved in maternal care.
Yes.
Because this organ is so efficient at transfer, it also means that many substances, including potentially harmful agents like certain medications, viruses, or substances of abuse, can cross directly from the maternal circulation into the fetal circulation.
That's a vital and maybe sometimes surprising implication of its efficiency.
Absolutely. And then there's the endocrine function. The placenta produces essential hormones for pregnancy.
Like what?
HCG, human chorionic gonadotropin, which maintains the corpus luteum early on and stimulates fetal testes if it's a male fetus. Human placental lactogen, HPLHCS, which supports fetal growth and breast development. Estrogen, which enlarges the uterus, external genitalia, and stimulates breast ductal growth. And progesterone, which is absolutely essential to maintain the pregnancy by preparing the uterine lining, decidua, and reducing uterine contractility.
That's an incredible amount of work for one organ. And what about the fetal membranes and amniotic fluid, the bag of waters?
Right. The 2 fetal membranes are the amnion, which is the inner membrane closest to the fetus, and the chorion, the outer one. They're so close they often appear as one membrane.
And the amniotic fluid inside.
It has several vital functions that are worth remembering. It's primarily protective, it cushions the fetus against any bumps to the abdomen, and maintains a stable temperature like a perfectly calibrated swimming pool.
And it helps development.
Yes, it's crucial for developmental purposes too. It allows for symmetric growth, prevents the membranes from sticking to the fetus, and provides space and buoyancy for fetal movement. That movement is essential for musculoskeletal development.
Where does the fluid come from?
It originates mainly from fetal urine and also some fluid crossing from the maternal side across the amnion. It contains shed fetal skin cells and vernix. And it's not stagnant, it's continuously exchanged. The fetus swallows it, it gets absorbed through the GI tract, and wastes return the placenta.
What's a normal amount?
The volume normally increases throughout pregnancy, reaching about 700 to 800 milliliters at term. But abnormal volumes have significant clinical implications.
Like too little.
Oligohydramnios, which is a low volume, less than 50% of expected, or under 400 milliliter at term. This can be associated with problems like poor placental perfusion, preterm membrane rupture, core fetal lung development, and compression-related skeletal malformations.
And too much.
Hydramnios, or polyhydramnios. That's a high volume, often over 2,000 milliliter. This can be linked to things like poorly controlled maternal diabetes or certain fetal malformations, CNS, cardiac, GI, that might affect swallowing. It can also be seen with chromosomal anomalies or multifetal gestations.
So for nurses, seeing these volume issues is a red flag.
Definitely. It signals potential underlying problems and prompts further investigation.
Okay, let's unpack this next part. Fetal circulation. Since the fetus doesn't breathe air in utero, its circulatory system has these brilliant adaptations.
Designed specifically to prioritize oxygen delivery to the most vital organs, the heart and the brain. It's a masterpiece of evolutionary plumbing.
And there are 3 key fetal shunts that make this possible. What's the first one?
First, the ductus venosus. This is where that highly oxygenated blood coming from the umbilical vein largely bypasses the fetal liver. About a third of it shunts directly into the inferior vena cava, heading straight for the heart. Think of it like an express lane.
Okay. Second shunt.
The foramen oval. This is a crucial flap valve between the right and left atria in the fetal heart. As blood enters the right atrium, about 50 to 60% of it crosses through this opening into the left atrium.
Why is that important?
Because from the left atrium, it goes to the left ventricle and then out the aorta. This brilliantly ensures that the most highly oxygenated blood preferentially supplies the coronary arteries, feeding the heart itself, the carotid arteries, feeding the brain, and the subclavian arteries, feeding the upper body. The heart and brain get the best stuff first.
Clever. And the third shunt.
Finally, we have the ductus arteriosus. This connects the pulmonary artery directly to the descending aorta,
Effectively bypassing.
bypassing the lungs, since they aren't yet needed for gas exchange in utero. Its patency, meaning it stays open, is maintained by prostaglandins produced by the placenta and also by the low oxygen environment inside the womb.
It's truly fascinating how this system ensures optimal oxygenation for the most vital organs until the moment of birth.
It really is. And for those of you eager to learn more, we'll definitely cover how fetal circulation transitions dramatically after birth when we study newborn adaptation to extrauterine life later in your studies.
Great. Now let's talk about multifetal pregnancy twins, triplets, and beyond.
What's fascinating here is the increasing incidence of these pregnancies. They're becoming more common in the U.S.
Why is that?
It's largely due to factors like advanced maternal age people having babies later, and also the widespread use of fertility treatments that often induce multiple ovulations.
Okay, so we need to understand zygosity. What does that mean?
Zygosity describes how many fertilized eggs started the pregnancy. This then dictates the genetic relationship between the fetuses and, importantly, the placental setup.
So, fraternal twins.
Dizygotic, or fraternal twins, result from 2 ovas being fertilized by 2 separate sperm. They are essentially siblings who just happen to share a uterus. They typically have 2 separate placentas and 2 separate amniotic sacs.
And this type is more common with?
Often associated with increasing maternal age and ovulation induction therapies.
So, they're like any other siblings, just born at the same time?
Genetically speaking, yes. Precisely. On the other hand, you have monozygotic or identical twins.
These come from one egg.
Exactly. They develop from one single fertilized ovum that splits at some point early in development. These twins are genetic clones.
And their placental setup can vary.
Yes, and this is the fascinating part. Their placenta and sac setup depend entirely on when that splitting occurred. If the split happens very early, within the first few days.
They might have separate everything.
They might have 2 placentas and 2 sacs, similar to fraternal twins, but they're still genetically identical. If the split happens a bit later, say between days 4 and 8,
What happens then?
they'll usually share 1 placenta but still have 2 separate amniotic sacs. This is actually the most common scenario for identical twins.
And if the split is very late?
In very rare cases, if the split occurs very late, after day 8, they might end up sharing both 1 placenta and 1 amniotic sac. This setup carries the highest risk.
And this raises an important question. Why does this all matter? Does the number of placentas and sacs really affect the pregnancy management?
It absolutely does, and this is a critical nugget for future nurses. The number of placentas and sacs, what we call chorionicity and amnionicity, directly determines the level of monitoring needed during the pregnancy.
Because it impacts risk.
Directly impacts risk. For example, if identical twins share a placenta, there's a significant risk of complications like twin-to-twin transfusion syndrome, where blood flows unevenly between them, potentially harming both.
And if they share a septum?
There's a heightened risk of cord entanglement, where the umbilical cords can get twisted around each other, which can be very dangerous, even fatal.
Yeah.
So understanding zygosity, and specifically chorionicity and amnionicity, is absolutely crucial for anticipating these specific risks and guiding appropriate clinical management throughout the pregnancy. These pregnancies often require much closer surveillance.
Okay, so what does all this biological understanding mean for daily life and empowered decision-making?
It brings us to the crucial topic of family planning and contraception.
Right. Making informed choices.
Family planning is essentially about deciding if and when to become pregnant. It covers both preventing pregnancy through contraception and, conversely, helping facilitate conception for those who want to become pregnant.
And the nurse's role here is huge.
It's paramount. You should be asking about reproductive goals at basically every encounter, tailoring counseling to each client's unique preferences, their medical history, their life circumstances.
And reminding them that no method is perfect, right? Absolutely. And reevaluation is key because people often switch methods as their needs or maybe side effects change over time. Now, when discussing methods, safety first. Safety is always individualized.
Definitely. Certain conditions or behaviors make some options unsafe.
Like a history of blood clots, stroke, or especially tobacco, use these, make some options, particularly estrogen-containing methods, quite risky.
This is a critical safety note for nurses and all listeners. Clients who smoke, especially if they were 35 or older, absolutely should not use estrogen-containing methods like combined pills, the patch, or the ring.
Why not?
Because of a significantly increased risk of serious complications like blood clots, stroke, and heart attack.
Okay, crucial point.
Okay.
And equally crucial, STI protection.
Yes. We must stress that only condoms, along with abstinence, actually reduce the risk of sexually transmitted infections.
So we often recommend dual protection.
Yes, that's using a condom along with a more effective method of contraception like an IUD or implant when there's any possibility of STI exposure.
It covers both bases.
And for adolescents, they're a particularly vulnerable group. Ongoing, non-judgmental counseling is paramount. National goals specifically aim to increase their use of effective contraception to improve health outcomes. Okay, let's break down the vast array of contraceptive choices, understanding their general mechanisms, typical risks, and key benefits. For you nursing students, paying attention to the categories and the primary mechanisms will be really key for your future practice.
Where should we start? Permanent methods.
Let's start there. Permanent methods. For females, tubal sterilization involves surgically cutting, occluding, or removing the fallopian tubes. It's highly effective and permanent, but it does carry surgical risks like bleeding and infection.
And for males?
A vasectomy. This is usually an office procedure to cut or occlude the vas deferens, the tubes that carry sperm. It's generally very safe, maybe some mild post-op issues like bruising or swelling, but crucially,
it's not instantly effective.
Right. It's not immediately sterile. A semen analysis is needed about 8 to 16 weeks later to confirm sterility. So backup contraception is absolutely necessary until they get the all clear.
Okay. And then we have the long-acting reversible contraceptives, or LARCs. These are known for their top-tier efficacy, right?
Indeed. LARCs are highly effective, often considered first-line options for many clients because the user failure rate is so low, you don't have to remember to do something every day or week.
What are the main types?
The main types are IUDs, or intrauterine devices. First, the copper IUD Paragard. It's hormone-free, lasts up to 10 years, and has the added benefit of being usable for emergency contraception.
Downsides.
Its primary risks are potentially heavier or longer periods and more cramps, especially initially. Rare risks include perforation during insertion or expulsion.
And the hormonal IUDs.
Then there are levonorgestrel IUDs like Mirena, Kylena, Skyla, Liletta. These release a small amount of progestin locally in the uterus and last anywhere from 3 to 8 years, depending on the specific device.
And their effect on period.
These often lead to much lighter periods, or even amenorrhea, meaning periods stop altogether, which many users see as a benefit. But initial irregular bleeding or spotting is common. Same rare risks of perforation or expulsion apply.
Okay, what else falls under LRRCs?
The implant. This is a single, small progestin-releasing rod inserted just under the skin in the upper inner arm. It's effective for 3 years.
Main side effect.
Irregular bleeding is the most common side effect and the most common reason for discontinuation. Fertility returns quickly once it's removed.
And the injection.
Lastly, the injection, Depo-Provera. This is a progestin-only shot given every 13 weeks. Risks include irregular bleeding, potential weight gain, and a temporary decrease in bone mineral density with long-term use. Hence, caution about using it for more than 2 years usually.
And return to fertility.
A key point for nurses. All LARCs offer a relatively rapid return to fertility upon removal, except for Depo-Provera, which can sometimes cause a delayed return, taking several months for cycles to regulate.
Good to know. And what about the more common daily or weekly hormonal methods? The ones people have to remember more often.
Right. Those include combined oral contraceptives, COCs, the standard birth control pill. They contain both estrogen and progestin and are taken daily.
And the critical safety warning again?
Absolutely bears repeating.
Ugh.
Clients who smoke, especially those age 35 or older, should not use estrogen-containing methods due to that significantly increased risk of blood clots, stroke, and heart attack.
Other common side effects?
Nausea, breast tenderness, headaches, maybe some breakthrough bleeding. They can also interact with certain drugs and herbs, like St. John's wort, reducing effectiveness. And crucially, they offer absolutely no STI protection.
Is there a way to remember warning signs?
For nurses, the acronym ACS is helpful. Abdominal pain, severe. Chest pain, severe, or shortness of breath. Headaches, severe. Eye problems, blurred vision, flashing lights. Severe leg pain, like in the calf or thigh. These warrant immediate medical attention.
Okay, what about progestin-only pills?
Progestin-only pills, POPs, or mini pills, contain only progestin and are taken at the exact same time every single day with no hormone-free days.
More time-sensitive.
Yes, much more. Being even a few hours late requires backup contraception. They often cause irregular bleeding but have fewer contraindications than COCs, making them an option for people who can't take estrogen.
The patch.
The transdermal patch is a skin patch worn weekly for 3 weeks, followed by 1 patch-free week. It delivers estrogen and progestin through the skin. It carries similar estrogen-related risks as COCs, potential skin irritation, and may be slightly less effective in individuals with higher body weight.
And the ring.
The vaginal ring, Nuvaring Vera, is a flexible ring inserted into the vagina, typically left in for 3 weeks, and then removed for 1 week. It also releases estrogen and progestin. Similar estrogen risks apply, plus potential headaches or increased vaginal discharge.
Okay, let's move to barrier methods.
Yes, the male condom is still the best non-abstinence method for STI protection. Key counseling points for nurses. Always ask about latex allergies. Use polyurethane or polyisoprene if allergic, and remind clients that oil-based lubricants damage latex condoms.
Female condom.
The female internal condom, FC2, also provides STI protection. It lines the vagina. Importantly, it should not be used concurrently with a male condom as friction can cause breakage.
What about spermicides and sponges?
Spermicides are chemicals, often containing nonoxynol 9, placed in the vagina before sex. They're often used with other barriers like diaphragms, but aren't very effective alone. They can cause local irritation and offer no STI protection. Some studies even suggest they might increase HIV risks slightly by irritating tissues. The sponge, today, is a single-use polyurethane sponge containing spermicide. It's effective for up to 24 hours, regardless of how many times intercourse occurs. It carries a small risk of toxic shock syndrome, TSS, if left in too long.
Diaphragm and cervical cap.
The diaphragm and cervical cap are reusable devices made of silicone that are filled with spermicide and inserted to cover the cervix before intercourse. They require fitting by a provider. They provide no STI protection and have specific usage instructions, like not using them during menses and removing them within a certain time frame to reduce TSS risk. For nurses, the key here is thorough teaching on proper insertion, removal, and care for effectiveness.
And what about behavioral methods? Methods based on tracking cycles or actions?
Right. These include natural family planning or fertility awareness-based methods, FABMs. These involve identifying the fertile window through meticulous tracking of the menstrual cycle length, changes in cervical mucus consistency, and daily basal body temperature monitoring.
Requires dedication.
High motivation and accuracy are essential for effectiveness. They offer no STI protection. Abstinence, refraining from intercourse, is, of course, the only method that fully prevents both pregnancy and STIs when practiced consistently. Lactational amenorrhea method, LAM, involves frequent, exclusive breastfeeding, no supplements, day and night, that can suppress ovulation for a limited time, typically the first 6 months postpartum if menses haven't returned. But its effectiveness declines quickly with any supplementation or spacing of feeds beyond 4 to 6 hours.
Withdrawal.
Coitus interruptus, or withdrawal, has a high typical use failure rate because pre-ejaculate fluid released before ejaculation may contain sperm, and it requires perfect control. It offers no STI protection.
And if a method fails or sex was unprotected?
Then there's emergency contraception, EC. This is available as pills. Levonorgestrel-based pills are available over the counter, while ulipristal acetate requires a prescription, or the copper IUD can be inserted within 5 days.
How does it work? When should it be used?
EC pills work primarily by delaying or inhibiting ovulation. They may also affect sperm functions or the uterine lining. They are most effective when used as soon as possible after unprotected sex, ideally within 72 hours for levonorgestrel, or up to 120 hours, 5 days for ulipristal. The copper IUD is the most effective EC method. Crucially, EC pills do not disrupt an established pregnancy. This is a vital distinction for accurate patient counseling.
Okay, let's quickly unpack these counseling pearls you'll use constantly in practice, especially as future nurses. These are key takeaways.
Right, the quick hits.
First, STIs. Always advocate for dual protection. Remind clients that only condoms and abstinence truly reduce STI risk. Recommend using a condom alongside a more effective method of contraception when STI exposure is a possibility.
Second, postpartum and lactation. Avoid combined oral contraceptives, COCs, for the first 21 to maybe 42 days postpartum due to the increased risk of venous thromboembolism, VTE. Progestin-only pills, IUDs, the implant, and Depo-Provera are generally considered safer options during this time and compatible with breastfeeding.
Third, missed pills. Progestin-only pills are extremely time-critical. If a client is 3 or more hours late taking one, they need backup contraception, like condoms, for the next 2 days. For combined oral contraceptives, always follow your specific clinic's missed pill protocol, which usually involves taking the missed pill ASAP and using backup for 7 days if multiple pills are missed.
Fourth, be aware of drug interactions with hormonal contraceptives, especially oral ones. Certain anticonvulsants like phenytoin, carbamazepine, the antibiotic rifampin, some antiretrovirals used for HIV, and even the herbal supplement St. John's wort can significantly reduce their effectiveness.
Always ask about all medications and supplements.
And finally, know the warning signs for estrogen methods. Remember AIDs.
Yes. Clients should seek urgent evaluation if they experience abdominal pain, severe, chest pain, severe, or shortness of breath, headaches, severe, sudden, or worse than usual, eye problems, blurred vision, loss of vision, or severe leg pain or swelling, especially in one leg. These could signal serious complications like blood clot, stroke, or heart attack, and rapid assessment is vital. This raises an important question. What about those who want to conceive but are struggling? Let's transition to understanding infertility.
Right. Infertility is clinically defined as no conception after 12 months of regular unprotected intercourse. Or, if the birthing parent is 35 years or older, the time frame shortens to no conception after 6 months.
And it includes pregnancy loss.
Yes, it also includes recurrent pregnancy loss, typically defined as 2 or 3 losses before viability. We differentiate between primary infertility, meaning someone has never conceived, and secondary infertility, meaning they have conceived before but are now unable to do so again.
Is it common?
It's more common than many people think. Among U.S. women aged 15 to 49, current estimates suggest about 13.1% experience impaired fertility. For nursing students, understanding this definition is really the first step in providing informed and empathetic care.
And what's fascinating here is that nurses encounter infertility patients across nearly all healthcare settings, not just specialized fertility clinics.
Absolutely. You might see them in primary care discussing concerns, in the emergency department dealing with an early pregnancy loss or maybe post-procedure complications.
In peri-op for diagnostic or therapeutic procedures, in urology for male factor issues.
And certainly in OB settings. Often, patients who conceive after infertility are considered high-risk antepartum, intrapartum, or postpartum. After what is often a long, emotionally and financially taxing infertility journey, Postpartum and pediatric teams need to anticipate added psychosocial needs and provide robust support as these parents transition into parenthood. Your role is truly pervasive.
Okay. So what are the guiding principles of care in infertility?
There are a few key principles for a holistic approach. First, time matters significantly, especially as the birthing parent's age advances past 35, or if there's a known risk factor like absent periods, amenorrhea, or severe male factor infertility. In these cases, it's important to escalate the evaluation sooner rather than later. We follow a stepwise approach, generally starting with the least invasive, most reasonable option first, but always individualizing the plan based on the client's age, their specific diagnosis, their available resources, financial and otherwise, and their personal values.
And interpreting success rates.
Critically important to interpret success rates cautiously. These rates can vary widely by clinic, by the specific mix of patients they treat, and by the underlying diagnosis. Setting realistic expectations is very important for the client's emotional well-being throughout what can be a stressful process.
Building on that, let's explore the various therapies designed to facilitate pregnancy, starting with medications.
Yes, pharmacologic management often focuses on ovulation induction for those who don't ovulate regularly, an ovulation or oligo-ovulation, or sometimes for controlled multifollicular development during procedures like IUI or IVF.
What are common medications?
Common oral medications include clomiphene citrate or letrozole, which stimulate the pituitary to release more FSH and LH, encouraging follicle development. Injectable medications include HCG, human chorionic gonadotropin, often called the trigger shot, which mimics the natural LH surge to induce ovulation at a precise time. And HMG, human menopausal gonadotropin or other gonadotropins, are used for pituitary insufficiency or for more robust ovarian stimulation during IVF cycles.
And progesterone.
Progesterone is also commonly used for luteal phase support, helping prepare the uterine lining after procedures like IUI or IVF.
What are the key risks with these medications? This seems important for nurses to know.
Absolutely. A primary risk is multiple gestation twins, triplets, or more, which carries its own set of risks for both the parent and babies. Another serious, though less common risk is ovarian hyperstimulation syndrome, or OHSS.
What is OHSS?
This involves significant ovarian enlargement and fluid shifting out of the bloodstream into the abdomen or chest cavity, third spacing, potentially causing severe symptoms like bloating, pain, shortness of breath, and electrolyte imbalances. Prevention through careful dosing, serial ultrasound monitoring of follicle growth, and checking estradiol levels is paramount.
What about surgical options?
Surgical procedures also play a role, often involving minimally invasive techniques like laparoscopy or hysteroscopy to correct issues like pelvic adhesions, endometriosis implants, uterine fibroids or polyps, or tubal and male reproductive tract obstructions. For male factor infertility, varicocele repair, fixing dilated veins in the scrotum, might be considered, although the evidence for its efficacy in improving natural conception is somewhat mixed. Additionally, transcervical balloon tuboplasty can sometimes be used to open proximal fallopian tube blockages.
And then there's therapeutic insemination, often called IUI, intrauterine insemination. What's involved there?
This procedure involves placing specially prepared, washed, and concentrated sperm directly into the uterus around the time of ovulation.
Why do that?
It bypasses any punctual cervical factors, like hostile mucus, and places a high concentration of motile sperm closer to the fallopian tubes where fertilization occurs.
When is it indicated?
For situations like mild to moderate low sperm count or motility, hostile cervical mucus, unexplained infertility, or for individuals or couples using donor sperm, such as single parents by choice, or same-sex female couples.
What's critical for success?
A crucial part of the process is semen washing to remove prostaglandins, white blood cells, and seminal fluid, which could cause uterine cramping or infection. And precise timing with ovulation, often managed with medication and monitoring, is essential for success.
Okay, what about using donor gametes, sperm, or eggs?
When using donor gametes, rigorous screening is absolutely essential to ensure safety. Donor sperm undergoes extensive medical history review, infectious disease testing like HIV, hepatitis, STIs, and genetic carrier screening. Donor units are typically quarantined for about 6 months with repeat infectious disease testing before release to minimize transmission risk.
And the number of donations is limited.
Yes, the number of donations allowed from any single donor is usually limited by regulatory bodies or clinics to reduce the chance of inadvertent consanguinity, related individuals unknowingly having children together, in the future.
And donor eggs.
Donor eggs are an option for individuals with premature ovarian insufficiency, poor response to ovarian stimulation, advanced maternal age, certain genetic conditions, or repeated failed IVF fertilization. Egg donors also undergo comprehensive medical, infectious, and genetic screening. Recipients are counseled on any residual risks and their options for prenatal screening during pregnancy.
Then there's surrogacy. Can you clarify the types?
Sure, a gestational carrier, or gestational surrogate, is someone who carries an embryo created from the intended parents or donor's gametes, sperm and egg. She has no genetic link to the baby she carries.
Okay. And a traditional surrogate.
Traditional surrogate is someone who is inseminated with the intended father's sperm, or donor sperm, using her own egg. So she is both a genetic and gestational contributor to the pregnancy.
What are the key considerations here?
From a nursing, ethical, and legal standpoint, surrogacy requires robust psychosocial counseling and screening for all parties involved. Clear legal contracts addressing parentage, compensation, insurance coverage, and decision-making during pregnancy are essential. Anticipating potential custody complexities is crucial, especially with traditional surrogacy, although gestational surrogacy generally has clearer legal parentage pathways in most jurisdictions now. For nurses, the key takeaway is the complexity and the need for comprehensive, sensitive support for everyone involved.
And then we have the cutting edge, assisted reproductive technologies, or ART, with IVF being the most well-known.
Yes, IVF, or in vitro fertilization, is the most common RT procedure. It involves several steps.
Yeah.
Controlled ovarian stimulation to produce multiple mature eggs, retrieval of those eggs via a minor surgical procedure, fertilization with sperm in the laboratory, in vitro means in glass, culture of the resulting embryos for several days.
And then transfer back to the uterus.
Exactly. Followed by the careful transfer of one, or sometimes more, embryos back into the intended parent's or gestational carrier's uterus. There's a strong trend now towards single embryo transfer, SETI, whenever possible,
Why is single transfer preferred?
to lower the significant maternal and neonatal risks associated with multiple births, twins, triplets, etc. After transfer, progesterone is typically given for luteal phase support, and an ultrasound is used later to confirm if implantation occurred and if it's an intrauterine gestation, not ectopic.
And IVF is also used for genetic testing.
Yes, IVS is the primary method used when pre-implantation genetic testing, PGT, is desired. This involves taking a small biopsy from the embryos before transfer to screen them for specific chromosomal abnormalities like aneuploidy or known single gene disorders.
But it's important to manage expectations with IVF, isn't it?
Absolutely. What's fascinating and sometimes heartbreaking here is managing expectations. Not every oocyte retrieved will fertilize successfully. Not every fertilized egg will develop into a viable embryo, and certainly not every embryo transferred will implant and result in a live birth. It can be an emotionally challenging journey with uncertain outcomes.
And multiples are still a risk.
While SET reduces the risk, twins are still the most common multiple gestation resulting from ART. And higher-order multiples, triplets or more, though less common now, carry significant risks for both the pregnant person and the babies.
And PGT isn't foolproof.
No. While PGT can screen for certain abnormalities, it has limitations. Not all genetic or chromosomal abnormalities are detectable. Mosaicism, having cells with different genetic makeup within one embryo, can complicate interpretation and errors can occur. Standard prenatal screening or diagnostic testing, like CVS or amniocentesis, during pregnancy is still generally recommended even after PGT.
Okay, let's bring this together. What are the key nursing priorities and teaching points in infertility care?
This kind of care demands a truly holistic assessment. You need to consider the medical factors, yes, but also the reproductive history, psychosocial well-being, cultural beliefs, financial constraints, and the significant time pressures, especially with advanced maternal age.
So, key responsibilities include
Thorough risk counseling, discussing the potential for multiple gestation, the signs and symptoms of ovarian hyperstimulation syndrome, OHSS, and the slightly increased risk of ectopic pregnancy with certain procedures like IVF.
and medication teaching.
Absolutely crucial. Explaining the purpose of each drug, potential side effects, injection techniques if needed, the importance of monitoring appointments, and critically, when to call the clinic, for instance, for rapid weight gain, significant abdominal distension or pain, nausea, vomiting, or shortness of breath, which could indicate developing OHSS.
Preparing for procedures, too.
Yes, preparing clients for procedures like egg retrieval or embryo transfer, providing clear information on what to expect, pain control options, any activity restrictions afterwards, and warning signs of complications like infection or bleeding.
But it's not just physical care, is it?
Critically, no. Nurses provide immense emotional support. Infertility is often a profound experience accompanied by grief, anxiety, depression, and relationship stress. Normalizing these feelings, validating their experience, and offering resources like support groups or mental health referrals is absolutely essential.
And acknowledging the unique stresses even after achieving pregnancy.
Yes, it's important to acknowledge the unique anxieties and stresses that can come with pregnancy and parenting after a long and difficult infertility journey. They may need extra reassurance and support.
Finally, what about health equity in infertility care?
This is vital. Nurses need to discuss access barriers. Infertility treatment is often expensive and not fully covered by insurance. We need to help clients understand realistic costs, guide them towards reputable clinics and reliable resources like SART or Resolve, and help them interpret clinic success rates in their proper context, ensuring they have accurate information and comprehensive support throughout this complex and often overwhelming process. This raises an important question. Why is preventive care so crucial for biologic female clients across their entire lifespan, not just during reproductive years?
Good question. Why?
Because it proactively reduces illness and death from leading conditions, like cardiovascular disease, various cancers, breast, cervical, colorectal, and osteoporosis. It works by catching problems early, often before they become severe or symptomatic.
And specific providers focus on this.
Certified nurse midwives, CNMs, and women's health nurse practitioners, WHMPs, often play a key role in providing this comprehensive care, frequently within primary care settings.
So the core idea is?
The core nugget here is that preventive screening should ideally be done broadly at every appropriate visit, not just focusing narrowly on gynecological issues. Because prevention truly beats treatment, and earlier detection consistently improves outcomes.
And this aligns with national goals.
Exactly. It aligns with broad national health goals, like those from the Women's Health Initiative or Healthy People 2030, which target things like lowering obesity rates, reducing the burden of breast and cervical cancer, cutting rates of pelvic inflammatory disease and congenital syphilis, and decreasing deaths from coronary heart disease and stroke. Providers should consciously align their counseling and screening practices with these vital public health objectives.
Okay, and when we talk about preventive care, breast cancer screening is a cornerstone, especially for average-risk clients. What's involved?
We teach breast self-awareness. This isn't about rigid monthly exams anymore, but encouraging clients to simply know what's normal for their own breasts, the look and feel, and to report any changes promptly to their provider.
And mammography.
Mammography guidelines can vary slightly between organizations, but generally annual screening is recommended starting at age 45 for average-risk women, though they have the option to begin yearly screening between 40 and 44 after shared decision-making discussion with their provider about benefits and risks.
And after 55.
From age 55, screening can typically shift to every other year, or they can choose to continue annually if preferred. Screening should continue as long as the client is in good health and has a life expectancy of 10 years or more.
What about high-risk clients?
For high-risk clients, those with a strong family history, known genetic mutations like BRCA, or prior high-risk lesions, earlier initiation, more frequent screening, sometimes annually, and potentially supplemental imaging like MRI may be necessary.
How do we address common barriers to screening? People worry about radiation or discomfort.
Right. We need to reassure clients about the very low radiation exposure from modern mammograms. Suggest scheduling appointments for the week after their menses when breasts are typically less tender. And discuss cost coverage. Mammograms are usually covered as preventive care under the ACA or direct them to low-cost screening programs if needed.
And just for context, if breast cancer does spread, metastasize, where does it commonly go?
The most common sites of breast cancer metastasis are the bones, liver, lungs, and brain. In addition to breast self-awareness, vulvar self-examination, VSE, is also important, though less commonly discussed. Who should do this?
It's recommended monthly for clients over 18 or those who are sexually active, regardless of age.
How is it done?
The method involves using good lighting and a hand mirror to systematically inspect and palpate all areas of the vulva. The mons pubis, clitoris, labia minora and majora, perineum, and the area around the anus.
What should they look for?
They should report any new findings like growths, moles that change, sores or ulcers that don't heal, patches of white, red, or darkened skin, warts, or persistent itching, burning, or inflammation. This is particularly important given the rising incidence of HPV-related vulvar intraepithelial neoplasia, VINN, which is a pre-cancerous condition.
Okay. And then the pelvic examination, including the Pap test. What do nurses need to know about preparing clients?
For nurses, it's crucial to schedule these exams ideally when the client is not menstruating. Clients should be advised to avoid douching, using tampons, having intercourse, or using any vaginal medications or products for about 48 hours prior to the exam, as these can interfere with Pap test results.
And during the exam?
Have the client empty their bladder just before the exam for comfort. Explain each step of the exam clearly as you go. Position them comfortably in the lithotomy position, on their back with feet in stirrups, ensuring privacy with appropriate draping.
What about clients with a history of trauma or female genital cutting?
Sensitivity is absolutely paramount. For clients with a history of trauma, go slowly, explain everything, offer them control, like inserting the speculum themselves if they wish, and stop immediately if they become distressed. For clients who've experienced female genital cutting, FGC, be aware of potential anatomical changes, use smaller speculums if needed, adapt your approach, and understand that routine exams might be difficult or even contraindicated depending on the type of FGC. Ensuring comfort, dignity, and trust is key.
Another critical preventive measure is cervical cancer screening, which typically involves Pap tests and sometimes HPV co-testing. What's the main purpose?
The primary purpose is not usually to detect cancer itself, but to detect precancerous cervical cell changes, dysplasia or CIN. These changes, often caused by persistent high-risk HPV infection, typically take several years, often 3 to 7 years or more, to potentially progress to invasive cervical cancer.
So screening allows for early detection and treatment.
Exactly. It allows for timely treatment of these precancerous lesions, effectively preventing most cervical cancers from ever developing.
What are the current screening intervals recommended by organizations like ACOG?
Current guidelines generally recommend, for clients aged 21 to 29, a Pap test alone every 3 years. For those aged 30 to 65, the preferred method is co-testing, doing both a Pap test and an HPV test every 5 years. An acceptable alternative in this age group is a Pap test alone every 3 years.
When can screening stop?
For clients over 65, screening can generally stop if they have had adequate prior screening with normal results, for example, 3 consecutive negative PAPs or 2 consecutive negative co-tests within the last 10 years, with most recent within 5 years, and have no history of high-grade precancer, CIN2+. Screening should not be restarted once stopped for age.
What about after a hysterectomy?
If a client has had a total hysterectomy, meaning both the uterus and the cervix were removed for benign reasons, like fibroids, not cancer, and they have no history of CIN2+, cervical intraepithelial neoplasia grade 2 or worse, which is a higher-grade precancerous condition, then no further cervical cancer screening, Pap or HPV tests is needed. If the hysterectomy was subtotal, cervix left behind, or done for cancer, screening recommendations differ.
So these guidelines aim to optimize detection while minimizing unnecessary tests and procedures.
Exactly. It's a great example of evidence-based practice evolving over time to find the right balance. Okay, let's shift gears now to some common challenges in women's health and what nurses need to recognize, teach, and maybe triage across the lifespan. First up, cardiovascular disease, or CVD.
A hugely important topic.
Here's where it gets really interesting and maybe alarming. CVD is the leading cause of death in women in the U.S., but it often presents with atypical symptoms, very different from the classic Hollywood heart attack chest pain often depicted for men.
What kind of atypical symptoms?
Women experiencing a heart attack might feel shortness of breath, dyspnea, unusual fatigue, pain in the back, shoulders, or jaw, nausea, vomiting, or lightheadedness, sometimes without any chest pain at all. For nurses, recognizing these subtle signs is an absolutely key insight for timely intervention.
What are the major risk factors for women?
Many are shared with men. Hypertension, high blood pressure, diabetes, dyslipidemia, abnormal cholesterol, smoking, obesity, physical inactivity, and family history. But women also have unique risks.
Such as?
Autoimmune diseases like lupus or rheumatoid arthritis are more common in women and increase CVD risk. Also, pregnancy-related complications like gestational hypertension, preeclampsia, or gestational diabetes significantly increase a woman's lifetime risk of developing CVD later on.
So the nursing focus here involves
Screening blood pressure, lipids, and glucose regularly. Critically, assessing pregnancy history for those risk factors like preeclampsia, counseling on lifestyle modifications, diet, exercise, smoking cessation, promoting medication adherence for conditions like hypertension or diabetes, and ensuring urgent evaluation for any symptoms that could potentially indicate acute coronary syndrome, recognizing those atypical presentations.
Okay, moving on to disorders of the breast. What falls under this category?
These can range widely from common benign conditions to malignancy, Benign issues include fibrocystic change, which isn't really a disease, but describes lumpy, dense, often tender breast tissue that fluctuates with the menstrual cycle. Fibroadenomas are common, benign, solid, rubbery lumps, often found in younger women.
Other benign issues.
Mastalgia, which is just breast pain, often cyclical. Infections like mastitis, common during breastfeeding, or breast abscesses. And nipple discharge. While most nipple discharge is benign colectoria, any discharge that is spontaneous, bloody, or comes from only one duct warrants further evaluation.
And on the malignant side, breast cancer. What are the red flags nurses should look for?
Red flags include a new lump or mass that is hard, irregular, fixed, and doesn't change with the menstrual cycle. Skin changes like dimpling or puckering, redness, or peau d'orange, that orange peel-like texture of the skin caused by lymphatic blockage. Nipple changes like recent retraction or inversion, staling, or ulceration. And as mentioned, spontaneous bloody or unilateral nipple discharge.
So the nursing focus is multifaceted.
Yes, promoting adherence to recommended screening guidelines, teaching effective breast self-awareness, ensuring timely diagnostic workup like mammogram, ultrasound, biopsy for any suspicious findings, and providing education and emotional support to clients going through evaluation or diagnosis. Next, menstrual cycle disorders. This is a broad category, isn't it?
Very broad. It covers issues like amenorrhea, the absence of menstruation. This can be primary, meaning a person hasn't had their first period by age 15 or within 3 years of breast development, or secondary, meaning periods stop for 3 to 6 months after having previously been regular.
Other disorders.
Oligomenorrhea, which means infrequent periods, cycles longer than 35-45 days. Abnormal uterine bleeding, AUB, which is a catch-all term for bleeding that's irregular in frequency, duration, or amount. Heavy menstrual bleeding, or HMB, is a common type. And dysmenorrhea, or painful periods. It's important to distinguish primary dysmenorrhea, cramps due to prostaglandins, no underlying pathology, from secondary dysmenorrhea, pain due to an underlying condition like endometriosis, fibroids, or PID.
And PMS, PMDD.
Yes. Premenstrual syndrome, PMS, involves cyclical, physical, and emotional symptoms occurring in the luteal phase before menstruation. Premenstrual dysphoric disorder, PMDD, is a much more severe form with significant mood symptoms like depression, anxiety, and irritability that interfere with daily life.
What's the nursing focus for these?
First and foremost, always rule out pregnancy in anyone presenting with menstrual irregularities or amenorrhea. Assess for potential complications like anemia if bleeding is heavy. Evaluate the impact on the client's quality of life. Educate on management options, starting with lifestyle changes and NSAIDs for dysmenorrhea, potentially moving to hormonal therapies like OCPs or hormonal IUDs for AUB or dysmenorrhea, or SSRIs for severe PMDD, and know when to refer for further evaluation if symptoms are severe or secondary causes are suspected. We also need to briefly address abortion or the medical termination of pregnancy. What should nurses know?
Nurses should have a basic understanding of the available options. Medication abortion typically involves using mifepristone followed by misoprostol and is highly effective in early gestation, usually up to 10-11 weeks. Procedural abortion, like vacuum aspiration or dilation and evacuation, is performed in a clinical setting and can be done later in gestation depending on state laws and provider availability.
And the legal landscape is key.
Absolutely. It's crucial to remember that laws regulating abortion access, timing, and requirements vary significantly by state, especially since the overturning of Roe v. Wade. Access can be very limited in some areas.
So the nursing focuses.
Ensuring accurate gestational dating. Determining the client's Rh status, Rh-negative clients need ROGEM, providing unbiased information and informed consent according to legal and ethical standards, explaining what the client can expect during and after the chosen procedure, educating on warning signs of potential complications like excessive bleeding, soaking more than 2 pads per hour for 2 hours, severe abdominal pain not relieved by medication, fever, or foul-smelling discharge. And critically, providing compassionate, non-judgmental care and support throughout the process, respecting the client's decision and autonomy within the legal framework. Okay, a significant life stage for many women is menopause. What are the key features nurses should recognize?
Menopause is technically defined as 12 consecutive months without a menstrual period, marking the end of reproductive capacity. The transition period leading up to it, perimenopause, and the time after involve various symptoms due to declining estrogen levels. Common features include vasomotor symptoms, those classic hot flashes and night sweats.
Other common symptoms.
Changes in sleep patterns, insomnia is common. Shifts in mood and cognition, irritability, anxiety, difficulty concentrating. Genitourinary syndrome of menopause, GSM. This involves vaginal dryness, thinning tissues, atrophy, painful intercourse, dyspareunia, and increased risk of recurrent urinary tract infections, UTIs. And importantly, accelerated bone loss, increasing the risk of osteoporosis and fractures later on.
How is menopause managed?
Management focuses on symptom relief and long-term health. Strategies include lifestyle modifications, layers clothing, avoiding triggers for hot flashes, regular exercise. Non-hormonal options for symptom relief like SSRIs for vasomotor symptoms, vaginal lubricants, moisturizers for GSM. Hormone therapy, HT, using estrogen with or without progesterone is the most effective treatment for moderate to severe vasomotor symptoms and GSM, and also helps prevent bone loss. However,
There are risks.
yes, the benefits and risks of HT, like blood clots, stroke, certain cancers, must be carefully weighed for each individual, considering their age, time since menopause, symptoms, and personal family history. HT has specific contraindications, like history of breast cancer or VTE. Supporting bone health involves ensuring adequate calcium and vitamin D intake, regular weight-bearing exercise, and DEXA screening for bone density based on risk factors and age, usually starting around 65. Next, pelvic floor dysfunction. This is common but often underreported, isn't it? How does it typically present?
It can present in several ways. Urinary incontinence, involuntary leaking of urine. This can be stress incontinence, leaking with coughing, sneezing, laughing, urge incontinence, sudden, strong urge followed by leaking, or mixed. Another presentation is pelvic organ prolapse, POP, where pelvic organs like the bladder, cystocele, uterus, uterine prolapse, or rectum, rectocele, descend or bulge into the vagina due to weakened supportive tissues.
Other symptoms.
Clients might report a feeling of pelvic pressure, heaviness, or like something is falling out. It can also cause bowel symptoms, constipation, incomplete emptying, or sexual dysfunction, pain, decreased sensation.
What's the nursing focus here?
Sensitive screening is key, as many people are embarrassed to bring these issues up. Reassure them it's common and treatable. Recommend first-line treatments, which often involve pelvic floor physical therapy, PFPT, including Kegel exercises.
Yes, PFPT includes teaching proper Kegel exercises to strengthen the pelvic floor muscles, which helps improve sphincter control, reduce leaking, and provide better support for pelvic organs. It also includes bladder training for urge incontinence, lifestyle advice, weight management, constipation prevention, and sometimes the use of a pessary, a removable device inserted into the vagina to support prolapsed organs, and if those don't work.
Then medications for urge incontinence or surgical procedures for incontinence or prolapse might be discussed. Nurses should also identify red flags like acute urinary retention or ulceration of a prolapsed organ, which require more urgent referral. And finally, there are many common benign disorders of the reproductive tract. Can you list some key ones?
Sure. Uterine fibroids, leiomyomas, are very common non-cancerous growths of the uterine muscle. They can cause heavy menstrual bleeding, pelvic pain or pressure, bulk symptoms, and sometimes infertility or pregnancy complications. Endometriosis is a condition where tissue similar to the uterine lining grows outside the uterus, on ovaries, fallopian tubes, bowel, etc., causing cyclical pelvic pain, painful periods, painful intercourse, and often infertility.
Others.
Adenomyosis is when endometrial tissue grows into the muscular wall of the uterus, often leading to heavy, painful periods and an enlarged, tender uterus. Ovarian cysts are fluid-filled sacs on the ovary. Most are benign and resolve on their own, functional cysts, but some can cause pain or require monitoring surgery like dermoids or endometriomas. Endometrial or cervical polyps are usually benign growths that can cause abnormal bleeding, and Bartholin cysts or abscesses occur when the Bartholin glands near the vaginal opening gets blocked and potentially infected. So the nursing focus for these benign conditions is mainly
Thorough symptom assessment, understanding the pattern and severity of pain or bleeding, screening for anemia if heavy bleeding is reported, helping with pain control strategies, discussing the client's fertility goals as treatment choices can impact future pregnancy, and knowing when to escalate care for further imaging, like ultrasound, or referral for medical or surgical options based on symptoms and findings. Okay, let's shift to infectious disorders of the reproductive tract. This raises an important question. How do we protect two patients at once, the birthing parent and the newborn, when these infections are so common?
a critical consideration in perinatal care. Let's start with common vaginal infections. Vaginal candidiasis or a yeast infection. What are the clues?
Intense vulvar itching, pruritus, and soreness are hallmarks, often redness and swelling, usually a thick, white, odorless, cottage cheese-like vaginal discharge. The vaginal pH is typically normal, meaning less than or equal to 4.5.
What increases the risk?
Things like recent antibiotic use, which kills off normal protective bacteria, pregnancy, hormonal changes, uncontrolled diabetes, and immunosuppression. Diagnosis is often made clinically or confirmed with a wet mount showing yeast buds or hyphae. Treatment usually involves topical antifungal creams or suppositories, like miconazole or clotrimazole, or a single oral dose of fluconazole, though oral treatment is often avoided in pregnancy.
Preventive advice.
Advising clients to wear cotton underwear, avoid tight-fitting clothing, avoid douching or using scented feminine hygiene products, and manage underlying conditions like diabetes.
Okay, then there's bacterial vaginosis, or BV. What are its clues?
EV clues include a thin, grayish-white homogeneous vaginal discharge, a characteristic fishy odor often more noticeable after intercourse or during menses. The vaginal pH is elevated, usually greater than 4.5, and under the microscope, wet mount, you see clue cells, vaginal epithelial cells studded with bacteria. Itching is less common than with yeast.
Is it an STI? What are the risks?
BV isn't strictly considered an STI, but it's associated with sexual activity and represents an imbalance in the normal vaginal flora, overgrowth of anaerobic bacteria, decrease in lactobacilli. Critically, BV is associated with significant risks, especially in pregnancy: preterm birth, premature rupture of membranes, PPROM, and postpartum infections. It also increases susceptibility to acquiring other STIs like HIV, HSV, gonorrhea, and chlamydia.
How is it treated?
Treatment involves antibiotics, typically metronidazole, oral or vaginal gel, or clindamycin, vaginal cream or oral. Recurrence is unfortunately quite common. Partner treatment is not routinely recommended as it hasn't been shown to reduce recurrence. And then the big category for anyone working in maternal care: sexually transmitted infections, or STIs.
Yes. STIs are incredibly common in reproductive age clients. A key point is that they are often asymptomatic, especially in people assigned female at birth. Many laboring or postpartum patients will have either a current infection or a history of a prior STI.
So early recognition is key.
Absolutely key, because it protects two patients, the birthing parent and the newborn. Most common STIs are included in the standard initial prenatal lab panels once pregnancy is confirmed.
Like which ones?
Typically, screening includes tests for HIV, syphilis, hepatitis B surface antigen, HBsAg, chlamydia, and gonorrhea. Hepatitis C screening is also increasingly recommended for all pregnant people. Repeat screening in the third trimester is often done for those considered high risk or living in high prevalence areas. For nursing students, understanding the why behind each of these screenings is vital for patient safety.
And the maternal newborn implications here are things you absolutely cannot miss. These are crucial for your future practice.
That's right. Let's run through the big ones. For chlamydia and gonorrhea in the pregnant person, they're linked with complications like premature rupture of membranes, PPROM, chorioamnitis, infection of the amniotic fluid and membranes, and postpartum endometritis, uterine infection.
And for the newborn.
They can cause serious neonatal conjunctivitis,
Mm-hmm.
ophthalmia neonatorum, which can lead to blindness if untreated, or pneumonia. This is why treatment of the parent before or after delivery and routine neonatal eye prophylaxis, usually erythromycin ointment, right after birth, are so crucial.
Syphilis.
Syphilis is especially critical. An untreated maternal infection during pregnancy can cross the placenta and lead to devastating congenital syphilis in the newborn, causing stillbirth, death, or severe long-term health problems. Urgent penicillin therapy during pregnancy is the only effective treatment to prevent congenital syphilis if the client reports a penicillin allergy.
They still need penicillin.
Yes, they must be hospitalized and undergo a penicillin desensitization protocol. There are no effective alternatives during pregnancy.
HIV.
If the parent's HIV status is unknown at admission for labor, rapid HIV testing is essential. If positive, timely administration of intrapartum and neonatal antiretroviral therapy, ART, along with careful delivery planning, often scheduled cesarean if viral load isn't suppressed, can dramatically reduce the risk of perinatal transmission from parent to child, often to less than 1%.
Hepatitis B.
Newborns born to parents who test positive for hepatitis B surface antigen, HBsAg, need to receive both the HBV vaccine and hepatitis B immune globulin, HBIg, within hours of birth, ideally within 12 hours, to prevent transmission. Completing the vaccine series is also vital.
Genital herpes.
HSV. If the birthing parent has active genital herpes lesions or prodromal symptoms like tingling or burning suggesting an imminent outbreak, at the time of labor, a cesarean delivery is typically recommended to reduce the risk of the baby contracting potentially life-threatening neonatal herpes during vaginal birth.
Yeah.
Suppressive antiviral therapy is often offered in late pregnancy to reduce the chance of an outbreak at term.
And trichomonas and BV. We mentioned BV's risks.
Yes, Both Trichomonas vaginalis, another common STI, and bacterial vaginosis are associated with increased risks of preterm birth and postpartum infections. Treating these infections according to guidelines during pregnancy is important to try and mitigate these risks.
So, what are the overarching nursing priorities for managing STIs in this population?
Key priorities include verifying prenatal lab results upon admission,
Yeah.
retesting when indicated, for example, if initial screening was early, if high risk, or if status is unknown. Crucially, using trauma-informed, non-judgmental communication when discussing STIs, as these topics can be highly sensitive and carry stigma.
And practical measures.
Implementing appropriate isolation or precautions if required, for example, for active HSV lesions. Ensuring timely treatment of the parent. Critically, arranging treatment for partners or providing expedited partner therapy, EPT, where legally allowed and appropriate, to prevent reinfection of the parent.
And postpartum counseling.
Yes, the postpartum period is a key touchpoint for risk reduction counseling. This includes discussing consistent condom use, considering dual protection, condom plus more effective method, and offering vaccination for HPV and HBV if the client is not already immune. Nurses also need to ensure appropriate newborn follow-up is arranged if the baby was exposed to certain infections like syphilis, HIV, or HSV.
So the bottom line for healthcare providers is
Building routine STI screening into standard prenatal, intrapartum, and postpartum care protocols and acting quickly on unknown or positive results prevents significant maternal complications and devastating neonatal morbidity. It's a core responsibility of perinatal care.
Let's delve just a little deeper into specifics for some of those key STIs you mentioned. Chlamydia.
Chlamydia trachomatis is the most commonly reported bacterial STI. It's often asymptomatic, especially in females, but if untreated, it's a leading cause of pelvic inflammatory disease, PID, subsequent tubal factor infertility, and ectopic pregnancy. Screening is typically recommended annually for sexually active females under 25 and for older individuals with risk factors. All pregnant people should be screened at their first prenatal visit.
Treatment in pregnancy.
Treatment usually involves a single dose of azithromycin or a 7-day course of amoxicillin. Doxycycline, often used otherwise, is contraindicated in pregnancy. Partners from the last 60 days also need evaluation and treatment. Retesting about 3 months after treatment is important due to high rates of reinfection.
Gonorrhea.
Neisseria gonorrhea often co-infects with chlamydia. Like chlamydia, it can be asymptomatic but can cause PID, infertility, and disseminated infection. A major concern with gonorrhea is rising antimicrobial resistance, making treatment choices more complex and requiring close surveillance. Current recommended treatment usually involves a single intramuscular IM dose of ceftriaxone. If chlamydia hasn't been ruled out, treatment for chlamydia, like doxycycline or azithromycin if pregnant, is often added. Partner management and retesting strategies are similar to chlamydia. Syphilis, we know it's critical in pregnancy.
Yes. Caused by the Spirochete treponema pallidum, syphilis presents in distinct stages if untreated. A painless sore chancre in the primary stage, a characteristic rash, often on palms and soles, and other lesions in the secondary stage, followed by a latent stage, asymptomatic but still infectious early on, and potentially devastating tertiary syphilis years later, affecting the heart, brain, and other organs. Screening is universal in pregnancy.
All pregnant people are screened at the first prenatal visit, and often again in the third trimester, and at delivery in high-risk populations, precisely because of the severe risk of congenital syphilis. As mentioned, penicillin, specifically benzathine penicillin G, is the only effective treatment during pregnancy, with the dosage and duration depending on the stage of syphilis. Allergy requires desensitization. Careful follow-up testing is needed to ensure treatment success.
Genital herpes, HSV.
Caused by herpes simplex virus type 1 or type 2, characterized by recurrent outbreaks of painful vesicles, blisters, and ulcers in the genital area, though initial infections can be severe, and some people have very mild or unrecognized symptoms. There is no cure, but antiviral medications, cyclover, valacyclover, famciclover, can help manage outbreaks, episodic therapy, or reduce the frequency of recurrences, suppressive therapy, and decrease transmission risk.
And in pregnancy.
The main concern is preventing transmission to the baby during delivery, neonatal herpes. Suppressive antiviral therapy is typically offered to pregnant people with a history of genital herpes starting around 36 weeks gestation to reduce the likelihood of an outbreak at term. Cesarean delivery is recommended if active lesions or prodromal symptoms are present during labor.
Human papillomavirus, HPV.
HPV is extremely common. Most sexually active people will acquire it at some point. There are many types. Low-risk types, like 6 and 11, primarily cause genital warts, condylomata acuminata. High-risk types, like 16 and 18, can cause persistent infections that lead to cellular changes, dysplasia, and eventually cancer, most notably cervical cancer, but also cancers of the vulva, vagina, anus, penis, and oropharynx, throat.
But there's prevention.
The incredible news here is that highly effective HPV vaccination is now routinely recommended for adolescents, both boys and girls, typically starting at age 11 to 12, and can prevent the majority of HPV-related cancers and genital warts. Screening for cervical cancer is done via PAP and HPV testing, as discussed earlier, with management of abnormal results based on specific risk-based guidelines. While there's no antiviral cure for the HPV infection itself, genital warts can be treated, though recurrence is common, and precancerous cervical lesions detected by screening can be treated to prevent cancer.
And finally, human immunodeficiency virus, HIV.
HIV attacks the immune system, specifically CD4 T cells, leading to acquired immunodeficiency syndrome, AIDS, if untreated. Opt-out testing is done unless the patient explicitly declines, is recommended for all adolescents and adults, including universally during pregnancy. Prevention strategies include consistent condom use, limiting partners, and for those at high risk, pre-IP, pre-exposure prophylaxis, taking daily antiviral medication to prevent infection, and PP, post-exposure prophylaxis, taking antivirals soon after a potential exposure. Early diagnosis and initiation of antiretroviral therapy, RT, are vital. Modern RT regimens are highly effective at suppressing the virus to undetectable levels. When the virus is undetectable, it protects the individual's health and prevents sexual transmission to partners. Undetectable, untransmittable, or U.
And in pregnancy.
As we discussed, continuing or initiating RT during pregnancy, using specific intrapartum RT protocols, and providing ART to the newborn dramatically reduces the risk of perinatal transmission to less than 1%. Specific delivery methods and infant feeding guidelines also apply.
Okay, let's touch on pelvic inflammatory disease, or PID. What is it?
PID is an infection of the upper female reproductive tract involving the uterus, endometritis, fallopian tubes, salpingitis, and potentially ovaries, ophiritis, or pelvic peritoneum. It's typically an ascending infection, often caused by untreated chlamydia or gonorrhea, though other bacteria can be involved.
Symptoms.
Symptoms can range from mild or vague to severe, but often include lower abdominal or pelvic pain, fever, abnormal vaginal discharge, often purulent, pain during intercourse, dyspareunia, and irregular bleeding. Cervical motion tenderness, uterine tenderness, or adnexal, ovary tube area, tenderness on pelvic exam are key diagnostic signs.
Complications are serious.
Yes, the complications of PID are significant and can be long-lasting. Tubal factor infertility, due to scarring of the fallopian tubes, ectopic pregnancy, chronic pelvic pain, and tubal ovarian abscesses. Prompt diagnosis and treatment are crucial to minimize these risks.
How is it treated?
Treatment requires broad-spectrum antibiotic coverage effective against likely pathogens, including chlamydia, gonorrhea, and anaerobes. Treatment regimens can be outpatient, oral antibiotics, or inpatient IV antibiotics, depending on severity. Inpatient admission is usually recommended for pregnant patients, severe illness, suspected pelvic abscess, inability to tolerate oral medication, or failed outpatient therapy. Partners also need evaluation and treatment. And finally, a rare but serious condition. Toxic shock syndrome, or TSS. What causes it?
TSS is a life-threatening toxin-mediated illness. It's most commonly caused by toxins produced by specific strains of Staphylococcus aureus, but can also be caused by group A streptococcus, the strep throat bacteria.
What's it associated with?
Historically, it was strongly associated with the use of high-absorbency tampons, particularly when left in place for extended periods. However, it can also occur with the use of other barrier contraceptives like diaphragms or sponges, menstrual cups, postpartum infections, or infections following surgery or skin wounds.
How does it present? It's sudden, right?
Yes, it typically presents with a sudden onset of high fever, often 102 degrees F, 38.9 degrees C, hypotension, low blood pressure leading to shock, and a diffuse sunburn-like erythematous rash that may later peel, especially on the palms and soles. Other symptoms include gastrointestinal upset, vomiting, diarrhea, muscle aches, headache, confusion, and evidence of multi-organ involvement like kidney or liver problems.
How is it managed? This sounds like an emergency.
It is a medical emergency requiring immediate hospitalization, often in an intensive care unit, ICU. Management involves, first, removing the source of infection if possible, like removing a tampon or draining an abscess. Then, aggressive intravenous fluid resuscitation to combat shock. administration of broad-spectrum IV antibiotics effective against staph and strep, and supportive care for organ dysfunction like ventilation or dialysis if needed.
Prevention focuses on.
Prevention primarily focuses on educating about safe tampon use, using the lowest absorbency needed for flow, changing tampons frequently, at least every 4 to 8 hours, alternating tampons with pads, and maintaining good hand hygiene before insertion. Avoiding tampon use altogether postpartum or if there's a history of TSS is also advised. For nurses, recognizing the rapid onset and characteristic constellation of symptoms, fever, rash, hypotension, is absolutely paramount for initiating life-saving treatment quickly. #outro. So what does this all mean?
Wow, we've just completed a really comprehensive deep dive into the foundations of obstetric care. We've covered everything from the broad societal context, the complex interplay of culture and ethics,
To the intricate biological blueprint of reproduction.
and the practical application of essential nursing knowledge. We move through basic anatomy, the miracle of conception, family planning choices and challenges like infertility, and vital lifelong women's health concerns. This material truly bridges science, complex systems, and those crucial human factors, highlighting the dynamic nature of the care you'll encounter in practice. What's fascinating here, I think, is that even with all this comprehensive information, the true art of providing safe, equitable OB nursing really comes down to recognizing that a pregnant client essentially presents two patients, the breathing parent and the developing fetus or newborn.
That's a powerful point.
And this raises an important question for you, the listener, especially if you're heading into this field. How will you actively use this foundational knowledge, these crucial insights into biology, social context, ethical responsibilities, to consistently anticipate risks, personalize education effectively, and ultimately protect both individuals every single time you provide care?
That's a profound responsibility.
It is. Continue to learn, continue to question, and apply this knowledge with vigilance and genuine compassion.
That's a powerful thought to leave everyone with. We really encourage you to reflect on all the concepts we've discussed today, maybe revisit any areas that sparked particular curiosity or felt complex, and definitely apply this knowledge as you continue your journey in understanding reproductive health.
Absolutely.
Until next time on the Deep Dive, stay curious and keep diving deep.